Hello, everyone. Back again. Dr. King here to talk to you about sleep-wake disorders. And I'm going to share with you my PowerPoint here. So, sleep disorders are categorized into 10 disorders or disorder groups. We have insomnia disorder, hypersomnolence disorder, narcolepsy, breathing-related sleep disorders, circadian rhythm sleep-wake disorders, non-rapid eye movement sleep arousal disorder, nightmare disorder, REM sleep disorder or rapid eye movement sleep behavior disorder, restless leg syndrome, and substance or medication-induced sleep disorder. So let's talk about types of sleep. So we have REM sleep. I'm sure you've all heard of REM. And that stands for rapid eye movement, and that's when dreaming occurs, and brain waves are very similar to wakefulness. And then we have other stages of sleep that are included. So there's 4 stages of sleep. One stage is the REM stage, and then the rest are non-REM sleep states. And so we have NREM stage 1, which is light sleep, 5 to 10 minutes transition between sleep and wakefulness. Non-REM stage 2, heart rate drops, breathing slows, temperature drops for about 20 minutes. And then you enter non-REM stage 3, where the muscles relax, the heart rate drops, and you're in your heaviest sleep state. All right, so as mentioned before, stage 1 is the transition from wakefulness to sleep. So you could be easily awakened here. You might be just falling asleep. And then you move into the next stage, which is stage 2, and it's associated with a predominance of theta waves in the brain and with the appearance of highly characteristic sleep spindle and K complex waveforms. And this takes 30 to 50 minutes to move from this stage to the next. And then you get into stages 3 and 4, which are known as deep sleep stages, slow wave sleep, or delta brain waves sleep. And reports of dreams are infrequent, and the images are much less vivid compared to dreams emerging from REM sleep. The proportion of time for an adult in each of these types and phases of sleep is 25% REM and 75% non-REM sleep. Stage 1 is about 5%, stage 2 is about 45%, and stage 3, or slow wave sleep, is about 25%. So abnormalities in timing, distribution, and proportion of different types and phases are found in sleep disorders and psychiatric conditions such as depression. Actigraphy is an objective, non-invasive, and relatively cost-effective means of estimating sleep-wake patterns. Movement data is used to determine sleep and wake periods, like physical movement. Common variables include your total sleep time, sleep onset latency, wake time after sleep onset, and sleep efficiency. So if you look at the neuroscience of sleep, polysomnography is also called a sleep study or a test used to diagnose sleep disorders, records brain waves and the oxygen level in your blood, heart rate, and breathing, as well as eye and leg movements during the study. If you're studying sleep, you may also use an EEG or electroencephalography, which records brain waves, or electroaquilography, an EOG. Please don't judge me on my pronunciation here, measures movement of the eye, and then electromyography, or an EMG, which measures muscle tone and activity. Some of the disorders of inadequate or excessive sleep include insomnia disorder, hypersomnolence, and narcolepsy. And narcolepsy is much less prevalent in the general population. It's commonly comorbid with affective and other types of psychopathology. And so some of the sleep disorder criteria is for all sleep disorders, sleep disturbance or associated daytime fatigue causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. It does not occur exclusively during the course of another mental disorder. Example, depression, PTSD, and they're not due to direct physiological effects of a substance like drug abuse medication, drugs of abuse or abusing medications, or a medication that causes sleep disturbances, or a general medical condition. So many mental health issues can affect sleep. Depression, anxiety. Depression can cause hypersomnolence, or it can cause insomnia. Same with anxiety. Anxiety usually on the side of insomnia. PTSD can definitely disrupt sleep. So you want to rule out those other disorders. If the primary concern is a sleep disorder, then that's what you want to go with. Let's talk about insomnia disorder. So insomnia is a predominant complaint of dissatisfaction with sleep quantity or quality associated with difficulty initiating sleep, difficulty maintaining sleep, like frequent awakenings, and early morning awakening with inability to return to sleep. This occurs at least 3 nights a week for 3 months, and despite adequate opportunity for sleep. So this is not because someone just had a baby and they can't sleep, but they could if they had the opportunity. It's, despite their best attempts at finding peaceful rest, they're unable to sleep. And the sleep disturbance does not occur exclusively during the course of narcolepsy, a breathing-related sleep disorder, or circadian rhythm sleep disorder, or parasomnia. Insomnia is the most prevalent of all the sleep disorders in the general population and in those who are seeking treatment for primary care or mental health professionals. So the 20% prevalence rate in the general population is pretty dang high. More prevalent in women and older patients, and commonly a comorbid condition with a medical or psychiatric disorder. 50% meet criteria for mental health diagnosis, usually anxiety or depression. So it doesn't mean that you wouldn't necessarily still diagnose someone with insomnia disorder. It's just the one that is impacting the person more dramatically will be listed first. And of course, not all mental illnesses or disorders that impact sleep meet the full criteria for insomnia. So you want to make sure that if you're looking at a sleep-wake disorder as a diagnosis, that you are making sure that they meet the full criteria for the diagnosis of insomnia or hypersomnolence or narcolepsy, any of the sleep-wake disorders that you might want to diagnose. So hypersomnolence, let's talk about that. Hypersomnolence is sleeping too much. It's the opposite of insomnia. So self-reported excessive sleepiness, despite a main period lasting at least 7 hours and at least one of the following: recurrent sleep periods within the same day, more than 9 hours of sleep that is non-restorative, difficulty being fully awake after abrupt awakening, at least 3 nights a week for at least 3 months. The somnolence does not occur exclusively during the course of narcolepsy, breathing-related sleep disorder, circadian rhythm sleep disorder, or parasomnia. So the person is sleeping at least 7 hours a night, and they're having multiple recurrent sleep periods within the same day. So they're sleeping 7 hours, then they're waking up, then they're sleeping again, they're napping frequently, and they're sleeping more than 9 hours of sleep that's non-restorative. So they're not even feeling great when they wake up. And they have a hard time being fully awake after abrupt awakening. So, they're sleeping a whole lot, but it's not making them feel rested. 5 to 10% of patients who seek treatment for excessive daytime sleepiness suffer from hypersomnolence disorder. It's estimated to affect 1% of the US and European populations, and males and females are affected equally, and onset is often progressive with mean age of onset between 15 and 25 years of age. All right, let's talk about narcolepsy. Narcolepsy is characterized by recurrent periods of irrepressible need to sleep, lapsing into sleep, or napping occurring within the same day, occurring at least 3 times per week over the last 3 months. The presence of one of the following is present: episodes of cataplexy, which is defined as either in individuals with long-standing disease disease, episodes of sudden bilateral loss of muscle tone with maintained consciousness that are precipitated by laughter or joking. So that means like their body goes limp. Their muscles are not working the way that they should. And there's often some sort of inappropriate emotional reaction, or maybe an appropriate emotional reaction, but then it's followed by this loss of, muscular control and sleep. And in children or in individuals within 6 months of onset, spontaneous grimaces or jaw-opening episodes with tongue thrusting or global hypotonia without any obvious emotional triggers. So maybe making bizarre, for children or in adults, making faces, grimaces, or other, episodes. And this is caused by a hypocretin deficiency. So this is a hormonal issue, and it's measured by using cerebrospinal fluids. They're going to look at your cerebrospinal fluid to see if there are appropriate levels of hypocretin. And nocturnal sleep polysomnography is showing REM sleep latency less than or equal to 15 minutes. So you are not having very much REM sleep, or AMSLT showing a mean sleep latency less than or equal to 8 minutes or 2 or more sleep onset REM periods. Prevalence of classic narcolepsy with emotion-triggered cataplexy is approximately 0.02% to 0.05%. So it's very rare in the population. And there's an equal incidence in men and women. And approximately 30% of narcoleptics suffer from excessive daytime sleepiness and sleep onset REM, but have no history of cataplexy. And approximately 20% report sleep paralysis upon falling asleep or awakening. So sleep paralysis, like meaning that you can't really move your body, you're just sleeping. And this is associated with insomnia. So these narcoleptic episodes can occur throughout the day, and then it impacts the ability for the person to sleep at night. Diagnostic considerations. You want to look at the DSM-5 criteria for insomnia and hypersomnolence disorders, including co-occurring medical, psychiatric, and or other sleep disorders as unique specifiers rather than exclusions for DSM diagnosis. There's a high rate of comorbidity. Up to 70% of patients with GAD have insomnia. Hypersomnolence and depression are highly associated. So, so generalized anxiety disorder can really lead to insomnia, and hypersomnolence and depression are highly associated. Then we have the Klein-Levin syndrome. So I have a link here that I'd love for you to check out. It's the Sleeping Beauty syndrome. Take a look when you can. And narcolepsy commonly occurs with depressive symptoms and other sleep problems, circadian rhythm, sleep-wake disorder, and restless leg syndrome. So you want to make sure you're ruling those all out. You're going to do a psychological and biological assessment. So, okay, all of these assessments are things that you would do. You would refer them to a full assessment for what we talked about earlier. Those polysomnography, an EEG, an EOG, an EMG, all those different things. We're not really trained to do those. So it might be useful at the beginning if you're not really sure what it is to do a sleep log or journaling to kind of help and figure out what's going on. Or even if someone has their Fitbit app, you could talk about it a little bit. But this is something that you would want to, if they're having very serious issues with this, they're going to want to get possibly, medication and some more intense treatment than really we can provide as mental health counselors. So you would want to refer them to further testing from a medical doctor. So etiological considerations. So where does this come from? Up to about 50% of insomnia patients meet, as we mentioned, criteria for comorbid mental health diagnosis, usually anxiety or depression. The onset in childhood is prognostic for later mental illness and adult sleep problems. So if they have these sleep problems early on, they're more likely to experience them as adults. Several neurotransmitter systems are involved in arousal, and some individuals with hypersomnolence have a family history of the disorder. Somnolence may result from viral infection or from traumatic brain injury. So you may want to, rule out those causes. And lesions in the frontal and occipital lobes, hippocampus, and amygdala have been associated with hypersomnia. Of course, that would require brain scans and all that stuff to try to understand, and that would be out of our realm. But you would, want to take that into consideration just to have a better understanding that that's a possibility. More than 86% of obese patients with type 2 diabetes have breathing-related disorders, so that's something just to consider. Shift work, time zones changes, certain medications, and changes in routines may also result in circadian rhythm sleep disorders. And familial pattern of restless leg syndrome has been shown. 83% concordance rates in monozygotic twins. So basically they found that restless leg syndrome is genetic. So parasomnias are characterized by abnormal behavior or experiences or physiological events that occur in association with sleep or emerge during a specific sleep stage or during sleep-wake transitions. Most common are non-REM sleep arousal disorders and REM sleep behavior disorder, which represent admixtures of wake and sleep. And they often come to the attention of mental health providers due to the associated bizarre, wild, and sometimes dangerous behaviors. The most dramatic of which we can think of is like someone killing their partner in their sleep or something. It is possible to manifest that way as a parasomnia. So it can manifest in sleepwalking. Of course, I said that's the most dramatic way, but typically it's not at all that severe. It can manifest in sleepwalking, most commonly seen in children, or it's also called somnambulism, and it affects about 4% of American adults. Sleep paralysis, so not being able to move, and then, often people waking fearfully because they can't seem to move their body. REM sleep behavior disorder, which can include nightmares, night terrors, nocturnal sleep-related eating disorder, and teeth grinding. So people can even act out in their sleepwalking state and not know what's going on. They'll talk to you. They can have, incredible night terrors or experiences that happen in their sleep. So these are extreme, obviously. Take a look at this video. There's a link here in the PowerPoint to parasomnias and kind of what it might feel like to have one. I'm going to skip over that now, but I'd love for you to just take a moment in the PowerPoint to go back and look at it. And then there's nightmare disorder. So nightmare disorder is a repeated recurrences of extended, extremely dysphoric, and well-remembered dreams that usually involve efforts to avoid threats to survival, security, or physical integrity. And it occurs almost exclusively during REM sleep, and it's thus more likely to occur during the second half of the sleep period. And on awakening, the individual rapidly becomes oriented and alert. Nightmares are fairly common in childhood. About 6% adults have one nightmare a week. Only 1 to 2% have more frequent nightmares, which is making me think I might have nightmare disorder. Be careful with the DSM because you're going to start diagnosing yourself with everything or your loved ones. Peak ages are 10 to 29 for women and 30 to 49 for men. And it's highly associated with PTSD and may produce clinically significant insomnia. So non-REM sleep arousal disorders are repeated occurrence of incomplete arousals from non-REM sleep, usually occurring during the first and third of the nighttime sleep episode, typically brief, 10 minutes out of an hour, and accompanied by one of the following: sleepwalking, walking around, blank staring face, relatively unresponsive, and sleep terrors. So recurrent episodes of abrupt terror arousals in sleep, usually beginning with a panicky scream, intense fear, and autonomic arousal is present. Tachycardia, so your heart's beating really fast, rapid breathing, sweating, and relatively unresponsive to efforts of others to comfort, and little or no dream images recalled, and amnesia for the episode is present. 10 to 30% of children have at least one sleepwalking episode, and 2% sleepwalk often. That's pretty high. Prevalence is lower in adults, and sleep terrors are more common in children. 20% of young children with 4 to 5% experiencing one or more episodes a week, and 75% of patients with sleep terrors will report sleepwalking. REM sleep behavior disorder. So this is repeated episodes of arousal during sleep associated with vocalization and or complex motor behaviors. Behaviors arrive during REM sleep, and therefore, so this differs from the last because it happens during REM, and usually that's why it happens a little longer, and it can occur for more than 90 minutes after sleep onset and is more frequent during later portions of the sleep period. It's uncommon during daytime naps. Upon waking from the episode, the individual is completely awake, alert, and not confused or disoriented, and either of the following occurs: REM sleep without atonia on PSG recording, and history suggestive of REM sleep behavior disorder, and an established synucleinopathy diagnosis or Parkinson's disease. So again, we're not going to know this stuff as counselors unless they tell us or we read it on their, like on their their medical history information if they bring it to you. So REM sleep behavior usually appears in adulthood, and men over 50 are most likely to be affected. So remember, this is the long-term 90 minutes REM sleep behavioral issues, like sleepwalking. When diagnosis is made earlier, it's about 50-50 men and women. Best prevalence estimate is 0.5% in the general population. So again, really small percentage of people. They're often able to recall dream content and usually notice when it's usually noticed, like someone comes to treatment when it causes danger to the patient. So they might hurt themselves in their sleepwalking state. And there's a comorbid narcolepsy occurs in about 30% of cases. So what might cause this? Genetic influence on nightmares is found to account for an estimated 45% of the phenotypic variants in childhood and 37% in adulthood. So it's genetic, it runs in the family. There's a high rate of heritability for sleep terrors, as well as sleep terror and sleepwalking comorbidity. There's no genetic test for REM sleep behavior disorder. Observations support brainstem normalities in the underlying pathophysiology. REM sleep behavior disorder may present years before medical disorders. So it might be an indication that Parkinson's disease could be on the way, unfortunately. And lesions or dysfunction in REM sleep and motor control circuitry in the pontomedullary structures is hypothesized to explain REM sleep behavior disorder years or decades before the onset of the neurodegenerative disease. Okay, so that's all I have for you for sleep-wake disorders. Take a look at the 2 links to get an idea of sleeping beauty disorder and the what was the other one? Parasomatic disorder. And I'm going to stop my share. If you have any questions, let me know. And have a great day.